So just to introduce everyone, I'm the Director of Critical Care and Resuscitation Research. For those who don't know, studying cardiac arrest has been my passion. Studying what happens when you die has been my passion for the past 25 years. And it's been a privilege to be here and try to develop a research program to both improve the survival for patients as well as reducing any potential brain injury, but also to try to disseminate this on a larger scale. You're going to hear about the lot of opportunities that we have to try to really save people's lives and save their brains. And my co-panelists tonight, we have Dr. Bob Montgomery, who you saw we started the film with. He is the director of the Transplant Institute here at NYU. He came here in 2016, right, from Johns Hopkins. He's really been a pioneer in transplantation. He's developed numerous techniques. He's a kidney transplant surgeon himself, but developed many, many methods, including the domino swap program. If you go to his office, he has numerous pictures with all the presidents that have been around the last 2 years. He won an award from President Bush, right? I think, for your domino program that you had. He's also in the Guinness World Book of Records 2010 as having performed the most kidney transplant surgeries in a day, and is referred to the most complex patients here. He's also now the chairman of surgery at the institution. Dr. Tom Aufdherheide, who you saw in the film also, is a professor of emergency medicine, a good friend and colleague of mine who's known each other for more than 10 years. He is the director of the NIH-funded Resuscitation Research Center, and has been working for many years to try to develop programs to save people's lives after cardiac arrest using extracorporeal membrane oxygenation. Lindsey Gurin is an assistant professor of neurology and psychiatry. She worked with me here in patients with brain injuries and trying to rehabilitate them. As you saw, has been helping us also studying consciousness and disorders of consciousness. And David, of course, Andrićević, joins us from Yale. He's a neuroscientist at Yale. He's part of the group who's been researching how to revive the dead pig brains that you saw, that we talked about, and he's going to talk about all of this insights. So without further ado, I'd like to join you guys and to sort of start our little discussion.
Just to mention that David is going to join us in our surgical residency starting in August. So he and we made a great decision.
Absolutely true. So let me start out by telling you, I want to, so we've had a whole film. I'll tell you what the challenges that I have in my life, and I'm going to bring it out to the open mic, is that we're trying to talk about PR issues. We're trying to show people that actually death can be reversed, and that we can bring people back, and that there is a lot of work that can be done. Yet, of course, the perceptions in society about life and death are so fixed. It is totally shut down when we talk about, when you use the word death. So think about the challenge that we have here to try to sort of make people, open people's eyes about the realities. And in part, that's what fueled us to produce the documentary. So I want to start with Bob. You heard in the film that he has survived seven sudden deaths. His heart stopped 7 times. He's with us. What you don't know, though, are some of the details behind this. Now, because if we wanted to go through the whole story, we'd have to give up the entire hour to talk about it. So I'm just going to tell you in brief what happened. Correct me if I'm wrong. So Bob's father was in the Gemini program in the 1960s, which was the space program before the US managed to go to the moon. And in his 40s, he suddenly suffered unexpected. He was actually a World War II bomber pilot who came back and joined the space program. And then he suddenly suffered a cardiac arrest. His heart stopped. As you saw from the film, cardiac arrest and death are the same thing. It's just that we use different terms to help us in society today, which we'll go into more detail. And he was actually revived the first time, but suffered a few more times. Unfortunately, ended up with severe brain damage, was in a vegetative state, and eventually died. Bob was very young. Then, when he started his internship at Johns Hopkins, he got a call in the middle of the night from his sister-in-law, who said that his brother, who had been water skiing, had suddenly let go of the rope. And when they turned the boat around to try to see what happened, they saw that he died in the water. They tried to revive him, but did not succeed. he realized at the time there was something going on in the male, in his father and his brother. And actually, when they examined his brother's heart, they realized that there is a hereditary problem, and that he's also going to get affected. So then, unfortunately, he suffered multiple cardiac arrests. By this time, he becomes a transplant surgeon. He's not able to get a transplant because there's such a scarcity of organs. There are not enough organs for people. So even though he's died 7 times, he wasn't able to get it. One of those happened during a Broadway show, where actually it was a showstopper, as he says. Literally, it was a showstopper. He had 45 minutes of resuscitation. The lady in the middle who's filming us is his wife, I believe, who's a soprano, a wonderful opera singer. Yes, exactly. And was there. He received 45 minutes of CPR. Apparently, by luck, there was a doctor and nurse who gave him very, very powerful CPR, broke some ribs, and as a result of that, he's alive. It's total luck, the fact that he's alive. But even then, he still couldn't get the heart transplant. Then you go to Italy, and I want you to pick up the story from there. So you go to Italy now, on a conference.
Yeah, so my wife was with me. I was at a medical conference, and it was the last night, and we were going to bed quite late, and I said, because I knew that I was developing ventricular tachycardia, and I fell on the stone floor, split my head open, and then proceeded to have 2 more cardiac arrests after that. It was sort of referred to as ventricular tachycardic storm. So every time I would sort of stabilize, then I would have another cardiac arrest. Now, what Sam didn't mention was that I had a defibrillator, an implantable defibrillator, that was put in actually when I was a resident after my brother died. And, at the time, they referred to what happened to my brother as sudden death. And then suddenly, with the advent of this new technology, an implantable defibrillator, you could reverse a sudden death, and you could be revived from a sudden death, because the longer that you go with a malignant arrhythmia, the less likely that you can be shot out of it. So if people don't just happen to have a defibrillator there, you're unlikely to recover. But with an implantable defibrillator, that changed everything. Now, it almost ended my career, and that's another story, but and it was a very primitive device at the time. It had just been invented. But the difference between my brother and myself was that device. And that device saved my life until it didn't. At the Broadway show, it didn't work. It wasn't able to convert. And then when I finally got to this point in Italy, where I had developed this very unstable situation, that was sort of the point where I could actually be admitted to the hospital and become a status 1 and have a chance to receive a transplant. But up until then, I didn't have, basically the cards that you needed. That's how bad our scarcity of organs are in this country.
And also, tell us about the decision that you had to make when you came back, right? You came back, you set up the Transplant Institute here, you hired a bunch of cardiologists, pulmonologists, and so on. And what happened in Italy? So I'm going to remind everyone. So, by the way, this gentleman is the must have half cat inside, I think, because he's obviously been 7 times and come back. He also recently went to Ukraine to help with their transplant program over there. And I'm like, how many opportunities he wants to be able to live? But he looks great.
Well, I think it's 7 for each heart.
For each heart. So when he was in Italy, what he told me was that he suffers a sudden cardiac arrest again now the 7th time, but he goes in and out every 20 minutes. He's going in and out. They rush him to the emergency room. The first person who meets him is a priest. What did he do?
Gave me the last rites. I said, that's a bit discouraging.
Exactly. But and somehow the Italian doctors really managed to stabilize his heart. And then you told them what? They just got you back. You're in the ICU with them. What did you tell them?
I said, I think now I have the tickets to get a transplant, so I'm going to have to leave. I'm really sorry. Thank you for what you've done. And I signed out against medical advice and conspired with a friend who flew back from Rome and got on the Lufthansa flight with the doctors were, they're Italian, so they're nice, compassionate people. They left my hip locks in and gave my friend a handful of pre-loaded syringes with resuscitation medications.
So they sent you off and said, good luck with adrenaline and Yojo and all these other medications, because of course the risk was you could have another on the plane.
Right, but what we hadn't mentioned is I spent a month in a coma in a similar type of hospital in Patagonia 2 years before that, and I didn't want to repeat that experience, so I knew I had to get back.
So we'll come to your transplant story in a moment. Now, I want to open up the discussion to the panel and also for your attention too. So one of the things we talked about is one of the challenges we face, actually, I certainly face as a physician in this field, is that we're all in society, but in society, including all the doctors, our perceptions of life and death are deeply ingrained in history. So we have this absolute sort of line that we try to draw between life and death in people. And that's the way society moves. We give people a time of death. It's very precise. It becomes a legal thing. Once we doctors declare somebody dead, that person loses all their rights. And so the reality that we try to show in this film, and I'd like to open up to the panel, is that despite the fact that we insist on viewing life and death as a binary event, but actually nothing in biology is binary. So there is no real line that exists, and that's what scientific advances are starting to show us between life and death. And so I want to open up really to the group. A lot of the challenges came about really after the late 1950s, 1960s with the discovery of CPR. Because until then, what used to happen was when your heart stopped, all signs of life were gone, and you could never go back again. So it was very clear, there was a clear line between life and death. That's why we think of a moment of life and death, because the heart stops. But of course with CPR, with the implantable defibrillator and so on and so forth that have been discovered, that changed everything. So Tom, tell us about how you see this. You've had a lifetime, as you said, in resuscitation science. You're an eminent professor, you're a multiple NIH-funded researcher, you've done incredible trials published in the Lancet and high-impact studies in this field. Tell us about how resuscitation science is changing our understanding of what happens well.
Well, I think Dr. Becker said it well. Originally, maybe 70 years ago, your heart stopped, you were considered dead. Then we discovered CPR, and then you were declared dead if resuscitation efforts failed. Brain death occurred in ICU patients probably 10 years after that. So our concept of death continues to evolve. And my own personal experience with ECMO, facilitated resuscitation, really kind of underscores that. ECMO is directed toward patients in cardiac arrest who are the worst of the worst. They don't respond to any standard treatment, and their survival rates are just a few percent. To characterize this, we define them as patients who have no response after 15 minutes, 3 shocks, and multiple medications. We then put them in the back of an ambulance with mechanical CPR, bring them to the hospital, and we place them on cardiopulmonary bypass because they are still in cardiac arrest. Average time for those patients is 1 hour of CPR. We now have patients, and we have a 45% essentially normal survival rate in that population. Even a few years ago, that was considered unattainable. We have patients now that we have about a 20% survival rate, high quality survival rate, near normal, with patients of over 1.5 hours of CPR. So having patients wake up and leave the hospital intact after that duration has taught us an awful lot. First, we know that the process of death is longer than we ever realized, that the brain is more resilient to ischemic insult, lack of blood flow, and lack of oxygen than we ever thought, and our patients are much more salvageable than we ever realized. I learned this on one of my first days of rounding on these patients, and I should say that this vision for ECMO was Dr. Dimitri Yiannopoulos at the University of Minnesota. I've collaborated with Dr. Yiannopoulos for since he was a resident, probably 20 years now, and it's a real privilege to be integral part of his research team. But I was rounding with, early on in our first patients, walked into a room, and there was a patient who had been there in the ICU for 1 week. There was no signs of life whatsoever. And I remember walking in and looking at that and saying, why are we doing that? We really should let this person go, and we need to shut these machines off. And I just thought that. And then we went to the next case and the next case. Well, the next day, we went into the same room with the same patient. And to my astonishment, he was sitting up in bed, looking around the room, pointing to his endotracheal tube, saying, "Take this out." So we extubated him. His wife was standing by the bed, and when he was extubated, he said a 4-letter expletive. His wife broke down in tears and wept for joy, realizing her husband was back. And in that same instant, I realized that everything I had been taught about the process of death was wrong. 3 minutes without oxygen and all is lost? No, that's just a myth, and that myth is no longer supported by the scientific evidence. The process of death is longer. Our patients are much more salvageable than we'd ever thought. And we have to reassess our own belief system in caring for these patients.
That's wonderful, Tom, actually. So, what you're pointing out is an incredible change that is not done across the country, unfortunately. Most people do not have access to what you get, and the survival rate stays at about 5% for most people whose heart stop. Now, a lot of people, you were telling me that a lot of people's perceptions are that these are people who have either terminal illness or maybe have reached a certain age, or that they've got organ failure, and as a result of that, they cannot be brought back to life. And the reality I want to point out is a lot of these people are young age, athletes, people who maybe in their 40s or 50s, men who get a sudden heart attack, who are otherwise staying dead and not being brought back to life because the optimal care is not being introduced. And I want us to talk about that a little bit later as well. But what you're showing us is that actually by implementing best care, you can make a huge difference and bring back patients' lives and an intact brain. Now, you mentioned something, because I don't know how many of our group here are doctors, but I would say that almost everyone who's trained in the medical field has been taught a sort of a mantra, which is that after about 5, maybe 10 minutes of oxygen deprivation, the brain is gone. It's finished. There's no point. Okay? And as a result of that belief system, what happens is a lot of doctors don't try very hard because they think it's impossible, because they're believing that it's gone. Lindsey, you're our neurologist in the film. You're a neurologist here. We work together closely. You were taught the same thing. I was taught the same thing. What is going on?
Yeah, so thank you. So yeah, as a neurologist, we are, I don't know if you guys know neurologists, we are notoriously pessimistic. So I work in brain injury rehab. Some of my brain injury rehab colleagues are here as well. And we specialize in treating people who have recovered from an event like this or brain injury. And so I am more, I think, open to this than many neurologists, but even, hearing the numbers you guys are talking about is mind-blowing to me. And hearing, Bob, you mentioned here, and I think in the film about, being in cardiac arrest for 45 minutes, having 45 minutes of CPR, and back in running a transplant institute. It's, this is incredible to see as a neurologist. And so I think it really does, as you're saying, kind of turn, how long really can you go without having kind of normal sort of cardiac function, and how long can we preserve the brain if you're doing very good CPR, if you're doing very good, if you have otherwise kind of good physiologic, so your health is otherwise good. You mentioned that young people sort of have these events, and I was thinking about a few months ago, there was in the news, some of you may have seen this, the football player, Mark Hamlin, who had a cardiac arrest on the field. And when that happened, my neurology colleagues texted me and said, "Oh, I see why, actually. You're talking about some people feel okay." And I think it was good, not just for non-medical, but also for medical people to really see that this is possible, but we're still learning about it.
Yeah. Well, I want to bring David into this. Before I do bring him in, I want to sort of tell you how the world has evolved, and then how I got to meet David, and then how he's here. Unfortunately, because of COVID, we weren't able to have him, and he works for Nenad Sestan, who is the director of the Sestan Laboratory at Yale. And he is our link to the study that we talked about, the big study that was in there. But I want to tell you, so what we're seeing essentially is, and I opened this up to the panel, is we had this very fixed idea of life and death, and it worked for thousands of years. And it led to this perception, which is built into our society, into the way we think, that we understand life and death as this separation. Cardiac arrest, or CPR, I should say, was discovered in 1959, and it blurred the boundaries, because now people who were dead could go back to life again. So what did we do in society? We decided to say, well, all right, we're going to stick to what we believe, so we're just going to call it something different. So now when the heart stops, we just call it cardiac arrest when we're intervening, and we label them dead when we stop intervening. Or if they didn't get any resuscitation, we label them dead. What then happened, as Tom mentioned also, is that it was discovered that actually, because of the advent of ventilators, people who used to get massive brain injuries and whose hearts would stop because they couldn't breathe anymore were able to be sustained in the intensive care unit. And it was discovered that actually the brain could undergo permanent damage, and the person may have no ability to recover from that. And so it became an ethical and moral challenge in the 1960s to get permission to recognize there could be another mode to declare somebody dead. Because ultimately, we are our consciousness, we are what our mind is. And if your brain is gone, why should we wait for the heart to stop? And so that led to the discovery of brain death as another way to declare people dead by legal means. But just to give you perspective, as we said in the film, 98% of people are declared dead when the heart stops. It's no different. Only a small proportion are declared dead before the heart stops, based upon this criteria. Now, I want to open that up to Lindsey, and then move on to this sort of what I think we're seeing now is a major revolution in our understanding of life and death. So if you could take us through our understanding of sort of brain death and some of the limitations that come, because it's really, again, we're trying to fix the time of death. We'll talk about that, and then I want to ask David to talk to us about the big studies.
Yeah, so I think as we referenced, this concept of brain death really came out of this idea that cardiac death, we can reverse it. So okay, we need something that's sort of less reversible to kind of draw the legal line for death. And so the concept of brain death really is about being able to say clinically, this person has an irreversible brain injury, and this, the brain function is never going to come back from this thing that has happened. So this requires basically doing an exam of someone, and through a clinical setting where there's been either a big brain bleed or they lost oxygen for a long period of time, and you're doing an exam that is showing essentially no function of the brainstem, and so we're looking for very basic reflexes like eye movements and breathing and things like that. And so what you want to do is sort of see that we're not seeing any evidence of brain activity of the brainstem, and we've excluded everything that could be kind of interfering, like there's no sedating medications, there's no kind of problems with kidney or liver function that could be getting in the way. And so we've ruled out everything else that this could be. To the best of our understanding, this is, the brain is not going to be able to recover from this. But so again, we sort of reach this sort of situation of kind of, well, how do we decide what's irreversible? And so we know that, we see this in sort of people with traumatic brain injury a lot of the time, where a brain injury can be very, very bad. There can be very, a lot of bleeding and stuff. But if you sort of give people full care, sometimes people can bounce back. And so kind of the question of what is an irreversible injury does become a little bit subjective, but we're doing is sort of the overall clinical context and trying to say that, as far as we've seen, this cannot recover from this.
And then, of course, David, tell us about what's been going on in Connecticut. So this challenges everything we've ever thought about life and death. So people don't believe sometimes what I say, and then I just have to point to Connecticut, what's been going on here in New Haven. That totally challenges us. All right, you saw in the film, these guys have been taking decapitated pig brains from a slaughterhouse. So these are animals who were killed for an experiment, and then what happened? What did your boss do?
So actually, that was really nicely mentioned in the movie that you can take parts of the human's brain after postmortem, after death, and then you can put those those pieces inside the petri dish, and we can do research on them. And so my boss was basically doing that. He's a developmental neuroscientist, and he was actually getting brains from UK, from London. There's a Wellcome Trust fund there that has a brain bank. So he would take the brains, and then is it DHL or FedEx? We can't remember.
He told me it was DHL.
So I don't want to name and shame.
That's right.
But, so the brains would actually travel across the ocean overnight, just being on the ice.
And these were human brains.
Human brains.
These were donated human brains. So people donated their brains for medical research, and the Wellcome Trust would ship them to any researcher who was,
You need to just pay for shipment.
Did they do that on Amazon?
Maybe in the future. So in essence, once brain actually they got delayed, and so brain actually got left on the ice for 48 hours before it missed the plane. And so it arrived basically a day and a half later.
The ice is melting, right?
To Yale, of course. Yes, of course. If you go in the plane high enough, it also gets colder. But still, it was almost 48 hours until the brain arrived from UK to us at Yale. And then, since he didn't want to be impolite, he didn't want to ship the brain back. He said to...
He told me, by the way, you can't exactly call customer service as a DHL.
Exactly.
That shipment of human brain that you were sending me was delayed for 48 hours. What would you do?
So in essence, he told a grad student at the time, so can you just try for practicing, can you try to slice that brain and try to use those cells in the cultures as we have seen in the movies? And then 2 weeks afterwards, the grad student came and told him, oh, look, actually the cells turned out to be great. And then he at first didn't believe him because it was 48 hours. Not 5 minutes, 48 hours. So, and then he first thought, oh, this must be some other brain. They're trying to fool me because we do those kinds of things. And however, no, it was that same brain. And then he got him thinking. That was basically the initial thought about, well, if those cells are still alive after 48 hours, what if we try to restore the circulation in the brain after a much, much shorter period? Because what he studies essentially are the brain connections. And to map those connections between the brain, you still need to have some sort of activity in the brain, so those connections can be mapped accordingly. And so that's how the whole idea started. And then soon afterwards, they started to perfuse the brain of those slaughterhouse animals. And they developed a machine that is based on heart-lung machine or ECMO, as we have heard. And they developed also a synthetic blood analog that was reperfusing those brains. And essentially, after 4 hours of ischemia, they managed to restore certain cellular functions in those brains, which was the study that's being mentioned.
I mean, what was remarkable is that Nenad says that I have a lot of them. I think he's going to become a Nobel Prize winner. I have no doubt about this, because what he's done is truly incredible. What he explained to me was that he went to his local Costco one day. He was trying to figure out, he didn't want to use experimental animals because he was thinking, well, it's not really right. What if this doesn't work? It's just an idea. I don't want to sacrifice any animals for this. So he looks and there's a slaughterhouse nearby. So he goes and knocks on the door. Can you imagine? This guy comes out and he's like, oh yes, I'm a professor at Yale. I was just wondering, do you have any brains I could take? So the guy's like, after a lot of, right?
Funnily enough, his accent is much deeper than mine. So, but first he actually went to Costco and he was searching also for, and also to local supermarkets, he was searching for a local sausage factory. And then he went to them first, and they said, well, we just get the meat. We need to actually go to the source. And that's how we ended up to the slaughterhouse.
And I think the long and short of it is that this was published in 2019, and it was absolutely extraordinary. They took these brains 4 hours after animals had been killed. They took them back to the lab. They connected them to a cannula, like you heard, because what we saw in the film is actually what we're understanding is that when we die, it's the cells in our body, in our brain, do not die, despite what we were all taught. Not quickly. They die very slowly. What happens is when we put oxygen back in, so when we do CPR and we restart the heart, the oxygen becomes toxic. It's called reperfusion or reoxygenation injury. And if you can understand that, then you can find a way to treat it and bring back people without brain damage. Nobody believed it. But what these guys did was they actually took these brains 32 times. They got the whole brain to work again. And they actually had given a drug to prevent the emergence of electricity on the brain, which was meant to protect the brain. And so when it came out, it was so extraordinary that no one knew what to do with it. So what they said was, well, we've got this biologically active brain, but we're going to say it's not alive, which again, like I said, doesn't make sense, right?
Yeah. Well, actually, especially both the first and the second study, we have to be really careful about what we're saying. So it's always mentioned that we have managed to restore certain cellular functions. And why that we're certain is because we have only shown that one that we can test. And of course, it's impossible to test every cellular function with just one gigantic paper out of it. So we always need to be really careful about what you're saying and not trying to extrapolate our data and trying to be more speculative. So
Yeah, in the spirit of being careful about what we say. So it was mentioned earlier about individuals who are brain dead, and that individual, their heart has been restarted at some point, and it's been restarted, when the brain had undergone significant ischemic injury, and then when it was restarted and the brain was reperfused, the brain rapidly died. So, in that individual, you can't, at least, in 2023, you cannot reverse that in any way. It's already done. It's done. But what we're talking about is intervening at an earlier point and reperfusing that brain in a way that could rescue or reanimate function. And the way I look at this whole thing is that there are these inflection points, right? CPR was probably the first inflection point. That was about 70 years ago. Now, I think that the great injustice is that we're still doing the same thing that we did 70 years ago, and there's probably nothing else in medicine that you could say that about. And I would say the second inflection point was the implantable defibrillator. The problem with the implantable defibrillators, you have to predict who's going to have a sudden death, right? So that is not something, we can't put a defibrillator in everybody, and believe me, you wouldn't want to have that. Because it comes with its own set of problems. But then I think the next inflection point was ECMO. Because ECMO then, it didn't require predicting when someone's going to have a cardiac arrest, because you could implement it at the time that they had a cardiac arrest. And then I think the next inflection point was the Yale experiments that basically said, if you put somebody on ECMO, but just don't put them on ECMO in the way we normally do, but you cool them and you provide a solution that helps to reduce the ischemia, actually the reperfusion injury, because it's not the ischemia that kills the cells; it's that combination of the ischemia plus improperly reperfusing.
Putting oxygen back in.
Yeah. So I think now we have a paradigm, and I personally feel that because look, if you have a witnessed cardiac arrest in the hospital, there's a 10% chance you'll leave the hospital. That was true 70 years ago, and that's true today. I think we can do better than that. And I think that it is a moral imperative for us to do better than that. We have a culture of safety and quality in this institution. And I think that, that we really have to think very seriously about when somebody comes into the ER or has an arrest in the ICU, of using these principles that we know that could potentially salvage the individual and their neurologic functioning. And I think in 5 years, every hospital is going to have an ECMO team that does that. But I think we should be the leaders in that. I think we should get out in front of this. And believe me, I'm not worried that that's going to mean that we're not going to have organs to use. I think just the opposite, that we will salvage the people's brains who could be salvaged, and those that we can't will have preserved their organs for transplantation if the family or that individual wanted that. So I think it's it's a win-win, and that we this is an important thing that we should be doing.
As an emergency physician, I'll make a friendly amendment about the comment that we're not doing anything. But you have to have a new intervention that works in order to move the field forward. We have implemented public access to fibrillation. That's saved thousands of lives over the year. ECMO, I think you're absolutely right on. ECMO facilitated resuscitation has been the next major step that we have now demonstrated moves the needle and makes a significant difference. It does because in clinical practice, the amount of ischemic time of those patients is reasonably short. That is, they've collapsed, someone's witnessed it, somebody's called 911, an ambulance shows up, and we're able to get them on bypass and ECMO within an hour or less, with a 45% normal survival rate. What I want to do next is what David is doing with the whole animal in a human. Because with 45%, we've gone from 0 to 45%. Huge, huge benefit. But 55% of our patients still die, mostly from a brain death. And David has now shown us the way of how we may do this in people as a next step and get to 70 or 80% in the future.
And I think the key thing here is that, I do want to sort of move on actually to the other question we talked about in film, but is that what you've shown, David, was we didn't actually go into a lot of detail because we talked about the 2019 study, but in 2022, and you're the lead author in Nature, which is probably the most prestigious publication, of a study where the team in Yale, headed by David, actually took pigs, not just the brains, actually had pigs, had their hearts stopped for an hour, kept them warm, and then took the device that they had developed, modified it, called it Organex, and were able to revive them again. And then they put it head to head against the ECMO, which for those of you, I'm sure you followed the film, it's basically a modified version of heart-lung bypass. And they were able to show that it outperformed the best of the best that we have. And what you've shown is you set the bar at what is capable of being done, that we can revive people who otherwise would be dead totally. Maybe just touch on that a little bit, because I also want to make sure we have time for questions and to go to talk about people's experiences with that and what happens to all of us, because ultimately that's a big question we have to address too.
So as you mentioned, so one minor would be that our technology, the Organex, was able to restore circulation and also recover certain cellular functions in multiple vital organs 1 hour after cardiac arrest. And so this whole concept, the whole technology is based on two things. One is the heart and lung machine, or ECMO, and as we like to joke, it's like an ECMO on steroids. So in essence, what makes it so special is we have added also an artificial kidney unit. We have added ability to pulsate, to mimic heart function as well, heart pulsability in essence. And also we have added lots of different reservoirs and pumps that actually allows a supplementation of this synthetic blood that we have developed. And that actually brings us to the second part, important part of our technology, which is our perfusing or synthetic blood analog. And that synthetic blood vest, in essence, it has its own oxygen carrier, and it has a drug cocktail that acts on certain cellular processes that happen during that 1 hour of complete ischemia or death. And also it has lots of different vitamins, amino acids, and metabolites that are actually aiding into the recovery of these cells. So altogether, basically, are crucial to achieve the effects that we have seen. So in essence, the machine restores the circulation and then allows the perfusate to reach out to all those individual cells to stop the cellular demise and to start the recovery.
And I think it's important just to point out very quickly, without too much detail, but what you've done, which is totally unique, is that you put, was it 11 or 12 different medications in there that stop the process by which cells get damaged. And that's the key thing. So it's really time to do this in humans now.
Yes, so the whole takeaway, if I need to specify just one thing, the whole message from the whole study, would be that the whole process, we have also seen now so many different perspectives, is that the whole process of cell death and of organ death in that case, to extend, is that it doesn't happen instantaneously, but rather it's a more protracted series of events. And by that being so, it allows us to intervene into that process to stop it and even reverse back to the organ.
That's wonderful. I mean, that's a wonderful description. So, I think what we're seeing is, as we look to the future, there's the potential literally to reverse death in people who otherwise were healthy. Clearly, obviously, if your organs have failed for other reasons, that's not possible. But if you're otherwise healthy, you die. I think in the future, we can potentially do this. And go ahead, please.
I just would add, I think the sort of closest equivalent to a natural situation we see this is in people where we think about the difference between people who have had a cardiac arrest and are not perfusing their brain, not getting oxygen to the brain, and then people who have had just a respiratory arrest. So let's say someone who has had a drug overdose is not breathing, but it still has, the heart is still beating. And so we know in those situations, it's not great not to have oxygen, but it is still much better to still be circulating blood and taking waste products away from the brain. And so we know that, as you mentioned, sort of when the brain cells start to die, it's a process. And so there is a cascade of events that happen. And if you can kind of whisk those byproducts away, you stop that signaling that's going to the other kind of surrounding neurons. You can try to preserve it as much as possible. So it's a really interesting avenue.
Yeah, there's definitely a window of opportunity.
Yeah, it's wonderful. Now we're hoping to work together, and so hopefully next time we come back, we'll be able to show a lot more about that. I do want to move on a little bit, if you don't mind, because there's a lot to talk about. Now, Bob, of course, your heart stopped 7 times. If it wasn't because of the defibrillator, as you said, we wouldn't be here today. If it wasn't for luck, actually, the people who resuscitated you, and now having had the transplant. And what was interesting to me is that you said that every time this happened, you felt like yourself, and by that I mean your consciousness, the part that makes us who we are, because we're all thinking conscious beings, our personhood. You described that this felt vast, that you seemed to get access to some knowledge that you otherwise wouldn't have. Tell us more about that, and then we'll sort of delve into essentially the bigger question, which is what happens to all of us when we go through that.
So I would say my experience with death is quite different than the individuals that you interviewed about theirs. And the interesting thing too is, in a way, I've had a control in my sense of the difference between death and hallucinations or vivid memories. and that's because I spent almost a month in a medical-induced coma, and I had some amazing experiences during that, which I think are more attuned to sort of, the experiences that people have taking psychotropic drugs and things like that. And that was completely different from my death experiences, not even the same. Even though those experiences that I had during that time felt so real, and it felt like they went on for a very long period of time. But the death experience for me was completely different than that, and it was different from what you heard. And it really involved, when I had cardiac arrest, lights out, and then there was what I call a transcendent consciousness, which was present. It was present before the cardiac arrest, and it was present after it was maintained, whereas my human consciousness disappeared. And I think that it's just there's a moment when I would be reemerging from death where the transcendent consciousness was all I had, and my human consciousness had not sort of reconstituted. And it was during that time that actually I felt this tremendous, expansive, vast, space or place that I was in, and then I would hear this noise. It was exactly the same every time. I would hear this noise, and this consciousness would say, "What is that sound?" And it sounded somewhat familiar, but I had no real capability of understanding what that sound is. That sound was the first couple of breaths that I was taking. And then what would happen soon after that is all sort of my human consciousness would rapidly, very rapidly refill. And there was a incredible compression and constriction of this vastness that I was experiencing, like something was being stuffed, inside like a ball. And it felt terrible. It felt absolutely horrific. But then my memories and my my human experience would begin to become clear, and I did feel a sense of appreciation that I was back into something that was familiar. And there's, I found someone who was able to really, I think, describe the feeling that I had perfectly. And this is someone who it's not from a death experience, but a conscious spiritual journey that this person had. So I think there is a way to access this place that I experience in death, that some people are able to actually access it, as living humans. But I think that everything that we are as a human and our human consciousness blocks it out. It somehow, you can't easily access this. Anyway, in his book called The Way of Subtraction, Sean Nevins says this quote that is perfect. It finally dawns. I am that which is never an object before consciousness. I am that which is never an object before consciousness. And that's exactly how I felt. That this transcendent consciousness has always been there. And that it was only when my earthly memories came back to me that I became, this human being that I am.
So can I go to Lindsey? I want to ask her with this now. So I've been studying this phenomenon for years, as you know. I mean, I started with this. I initially collected thousands of people who wrote to me with their experiences. And what I found was remarkable is that, and we're calling this lucid dying, is that as people are going through this death process, one of the things that really stands out, we were talking about it earlier, is that they're able, and you saw in the film as well, and what happens is they feel that their consciousness is more real, it's heightened, even though from our perspective they look like they're dead, there's nothing there. And incredibly, then they have this review of their entire life where they relive all their memories, all their actions, but importantly, all of their intentions and thoughts. Now, if I asked anybody in this audience, how much of your life could you recall? You won't be able to recall very much of it. So the question is, why is it that as we get through death, your brain is shutting down, you're going into this process, that suddenly you get access to your entire consciousness, everything that you have done. And importantly, these individuals start to reevaluate their life, as you saw from Rachel Finch and others, from a perspective of morality and ethics. She was saying that she was re-experiencing, if she had yelled at her parents, if she hurt their feelings, she was re-experiencing that and judging herself and saying, I could have done better as a human being. So why is it that at death this is occurring? And why is it that our perspective changes into that of morality and ethics? Just $1 million question for you guys.
I'll give you the neurologist sort of.
What happens when you wear the neurology hat?
That's exactly right. Yeah. So I'm here to be the the representative of Western science. That's how we call neurologists. So I would say, and Bob, I want to say thank you so much for sharing that story. It sounds so powerful and just so kind of incredible. I think some of the things that stand out to me about the story are one that it was they have the same experience at the time, right? And so I think if our doing neurology consult, I might say, oh, it's a stereotype event, right? It's a seizure. That's what that is. But I think that there's so much more there because it sort of connects to this larger theme that people describe kind of across these types of events. And we're talking a bit earlier, and we saw Dr. Rosses and Steve Ross kind of briefly shown in the film, but they do psychedelic work, right? So we're working with people taking psychedelics for therapeutic purposes. And so it's not exactly the same, but there is this sort of theme of sort of becoming, having this vast experience and becoming sort of greater than your sort of narrow kind of individual ego that you're living from day to day with. That this idea that we may, in these times of kind of sort of extreme situations at the time of death or in certain sort of under the influence of certain drugs, that the brain sort of our experience is opened up, and the things that are typically filtered out are maybe kind of introduced into our awareness, and that I think that is kind of maybe one way to explain how people are kind of consistently across different contexts having the same experience.
I mean, one of the things that I want to sort of end on panel discussion now and leave some time for questions, but I think when I got started in this field, everybody would reject these people's testimonies. You heard Dan Stern. His mother had no medical knowledge. She has this event, and she comes back and describes what's going on. And we used to reject that because we had no way of explaining it. And so we used to be like, oh, there, I know you think this happened, but Mrs. Sturman, this didn't really happen to you. You imagined it. It was all in your mind. Of course you knew all about adrenaline, CPR before all of this. And she said, no, I didn't. No, but you did. You think you did. You heard about Tom's experience. I've had other colleagues who told me as well. And I think what is fascinating, and we're beginning to discover, and there was a study that was in the news this week, and this has been shown many times before, and we've shown it ourselves here too, is that what seems to be happening as people die is that the first thing that happens is your brain flattens. and it flattens. We used to think it was dead, but actually it's a protective mechanism because it's preserving what it can. It reduces its activities and it shuts down. But normally what happens, of course, in order for us to function is we have braking systems. We have inhibition going on in our brain so we can focus on certain things. And what seems to be happening is as the brain is shutting down, the braking systems are removed and you get access to these parts of your brain that are otherwise dormant. This is called disinhibition. And we've seen this now. Studies have shown that you get this EEG, these brain markers, post-mortem in humans and animals that emerge after the heart stops. And it's consistent with lucid thought processes, these high-frequency gamma waves that occur, very high range, that you normally see when you're deeply contemplating an idea, maybe when you're watching this film. But yet it's occurring in people who die. And so the question really is, this is incredible because we thought death was the end, and what we're seeing is that actually we could push into the boundaries of death, and that these millions of people who provided these testimonies, like Dan Sterman's mothers and others, who were discarded, and their testimonies are probably real, and there is something phenomenal going on with death. And they're getting access to parts of their consciousness that they would normally not be able to access. So I think it's an absolutely phenomenal story that's evolving because we're recognizing that death is not the end, neither biological processes and nor does mental activity. And it's totally new field for us to research and explore.
By the way, when I was 14, my father had the Dan Sterman conversation with me and said to me, "You should never be afraid to die. It's an absolutely beautiful experience." And it's, and he sort of laid it out, for me at that point. And he was after his first cardiac arrest, he was a changed person. He was very different. And so anyway, that really, I would say, was the greatest gift that he ever gave me, actually.
That's wonderful. Thank you so much. Thank you, Bob. I want to thank the audience here for the time. I know it's getting late, and I want to open up to questions. We started a little bit late, so if anyone needs to leave at 7:27, but we'll maybe give 5 to 10 minutes for questions if anyone has anything you'd like to ask us. Otherwise, I believe if our delivery has arrived, we will have some light dinner outside for those who want to stay and discuss further afterwards as well. So, yes. And I think to pass microphones to
Thank you, Joe.
You're used to it.
So first of all, thank you. What an incredibly inspiring, really mind-provoking experience for any of us who've taken care of patients near death. Every one of these stories, we all have patients either experiencing this, describing things in their own lives as well. As a gastroenterologist, sedated with propofol, which, if you've ever been sedated with propofol, really takes away your consciousness. And what I'm wondering is if there is a human level consciousness and perhaps a higher level of consciousness, we're clearly taking the human level consciousness away in propofol. And for anyone who's been sedated with it, you're sedated for propofol, and then you wake up. It's as if time never existed. But I never hear anybody talking about any other level of consciousness. What is actually happening there neurologically, and is there something we can learn from that experience that might allow us to understand some of these other level of changes or conscious changes?
So you guys are looking at
You're the house neurologist, Lindsey, so we're looking at you.
So I think it's a great question, and it's I think sedation, being under deep sedation is sort of a different situation than we're talking about here. I think partly because so I guess it depends on the level of sedation, but you're sort of shutting down a lot of these kind of higher level cortical networks in theory, and it's I think we don't totally know, I guess, how much people are experiencing. And I think the other idea is that it may be that people are having some experiences but are not sort of creating memories during that time, and so that's, I think, a possibility also. I think it's being under anesthesia is, I think, different from kind of being at these liminal states kind of between life and death. And then also, I think, different from what we see in people who are minimally conscious. And we mentioned vegetative state, or what's now called the unresponsive wakefulness state, where people who do kind of recover from those states, are sometimes able to say, like, I sort of felt present, but not really, sort of not sort of in the same way. This idea that in the brainstem, the sort of most resilient part of the brain, that's where a lot of the nuclei that produce neurotransmitters live. And so you can have these kind of fundamental sort of emotional experiences and maybe even kind of larger experiences of love and kind of vastness and stuff without having the sort of more complex, higher level sort of thought processes that go along with them. So that if you have kind of intact brainstem emotional function separate from the cortex, that you might be having kind of these different experiences. So I sort of talked around your question, but it's I think all these kind of different, probably different states.
Did you have a question, lady in the middle?
Hi. Thank you guys all so much for your time. This was an awesome event to come to. I have two more like, I guess, consciousness-related biological questions, and then two more based on research in neuroscience. So I'll try to combine them, I guess. The first is, do you guys think there's a connection between how people were experiencing RED or the near-death experiences with trying to maybe inhibit pain or pain reaction and have end of life be related to minimizing pain or having the reaction be involved in the pain processing? And then similarly, do you think like the bringing back of memories or traumatic events is related to maybe some kind of conferring a benefit to people remembering traumatic memory and how that connects with life? And also, if you're seeing activity in like moral centers like RPTG, the right parietal temporal junction, which can be morally implicated, if we're seeing that in your research studies post.
I think, maybe I'll open up to the group, maybe just a quick answer. I think the thing, I just want to point out, these are not traumatic memories, actually.
Okay.
So I think what we're seeing, and to Dr. Chake, to the point that we're just saying here, is that clearly we don't understand what the human mind and God, everyone here has a unique world inside, right? We can't, and that was discussed in the film, we can't minimize it to a little bit of electricity. There is no mechanism to account how your thoughts arise from your brain processes. There is no mechanism. Yet you are a deeply conscious, thinking human being. Everyone's made a decision to be here tonight. We are unique. You have people, Mozart and Beethoven, and you have people who try to go to the moon, and you have people who try to tackle reversing death, and you have people who try to tackle COVID and so on. So we don't understand what the nature of human consciousness is, but I would like to say that people who die do not have traumatic experiences. Actually, they're reliving their entire life in a deeply purposeful manner. And the question we have to ask ourselves is there an evolution? Because nothing happens without a reason. So why is it that as people are preparing to go into this next journey, whatever that is, that what becomes real to them is that component, what they did. The things that we try to teach our children are important, yet in society we forget. But yet at death, it becomes real to us.
I mean, I would say that the experiences that I had, at that junction between being dead and then being alive were completely unearthly. They're not anything that I've experienced in any other state. And it was so profound that it, shook me to, the depth of who I am, that I had that experience. So I don't know how to explain that with, a bundle of neurons, where that place was. So, what I can say is it was spectacular, and it was a vast, not just a vast space, but my ability to process what was in that space was vast. And it was quickly able to be contrasted with the human experience, because that flooded back in as I became conscious again. So it was this very stark contrast. And again, it was so different than what I had, during time that I was in a coma and getting sedation and that sort of thing.
Yeah, I think I would add also, I think just to be the buzzkill again for a second, when you mentioned sort of the kind of, are we having this experience of people escaping pain or something stressful? I mean, if the other times that we know that people have experiences like what people are describing, that sort of being out of your body, kind of being above the, the top of the sort of near the ceiling above the room, dissociation. So times where people are in extreme stress, extreme trauma, they'll kind of remove, some people can have the experience of being outside their body, or seizure. Can also create that experience. And so, I think there's the sort of narrow, concrete way to look at that and say, look, these are the brain doing crazy things. This is what happens. Or there is, I think, the argument that this is an experience that you can get to by a number of ways, and that, maybe really is sort of we're touching upon something that, is not usually accessible to us in day-to-day life, but is there and can be reached under certain circumstances.
Wonderful, thank you. Maybe we'll just take one last question. I think another lady over there had a mic, and I do want to make sure we get you guys home in time to your families. So, yes.
Is it on? Okay. I almost have too many questions, so maybe it'll go for a drink afterward. We've been lonely. 2 questions, but I'll try to keep it to one. What have you seen in terms of recollections and near-death experiences cross-culturally? Are you also seeing similar experiences and patterns?
Maybe I'll address that very quickly. So actually, what's phenomenal is that this experience has been recorded and recorded all over the world. Numerous studies have been carried out. We conducted one of them ourselves across 8 countries, actually, with different cultures, different sort of parts of the world. And consistently around 10% of the population report having had these experiences. So if you multiply that by the adult population, you're looking at about 500 million people today are living with these experiences. Yet for years, they used to be dismissed. What's also incredible is that they all follow the same pattern, which is that essentially I recognized they were trying to save me. I recognized that I'm not dead. I could see this. I could watch them. They thought I was dead. I realized this must be my death. And then during that time, they have that review of their lives. And this is consistent, irrespective of where they come from. The only difference is that depending on people's background, their interpretations of what they see will change. So in the same way that if you and I see something, we may interpret it differently. We've studied thousands of patients' experiences. So I'm not just sort of, I have an overall view of what they say. The only difference is the interpretation, which is of course understandable, but the core features are universal, which is very different to hallucinatory type experiences. We've done numerous studies and shown that they're totally different. Because again, you and I see different things. We don't all have the same experiences during our dreams or during other hallucinatory events. But during the death experience, they're all the same. And again, I want to go back to Dr. Sturman. His mother is just one person among millions who've had them, who come back and they're able to describe exactly the same thing as somebody else in China, in India, in other parts of Asia, in South America, and so on, who don't know each other. None of them know each other. And they all get ridiculed.
So I guess I'm, once again, a little bit of an outlier, but because there are elements of my experience I think that are shared. But what I would ask you is, have you ever heard someone having a really bad trip, a bad experience with death?
No. But people have labeled different experiences, and that's a whole other panel discussion which we'll have to get into. But the reality is when you look at them, even if the only part that's bad for them, if you want to call it bad, is where they relive things that they felt ashamed about. But even that for them is an educational process. Like they learned that, I should have done better. I realized, like you saw with Rachel Finch when she was describing it. But they re-experience what's remarkable, and we'll end with that because I do want us to go and enjoy something to eat. But just remember what they describe is that if they caused pain to other people, they relive the exact same pain that the other person was having. And that's what Rachel Finch was explaining. Conversely, where they've helped other people, where they've been of benefit to other people, they re-experience that same happiness. So really, they're evaluating and judging their own life. And one final point I'd like to say, their descriptions are totally different. If you pay attention to this, they're totally different to religious concepts. Because actually, nobody who has this experience, and I've interviewed so many people, I'm like, this is remarkable. Nobody says, for example, that let's say if they're of a particular religious background, oh, I saw that I went to a place of worship. Nobody describes that. Nobody says I went to church every week, or I did this, or I did that, even if they're religious. And if they're an atheist, they'll still experience having had the purpose, what they had done. So my point is, if this was being made up in their mind, then they should be saying, oh, look, I went to temple, that's wonderful, I was being commended for my work. They don't. What they judge is what they did. So incredibly, it looks to be that what matters is what we do as human beings, and that's really the take-home message from it. So with that, I'd like to thank you all for your time.